let's just get into the COVID vaccine part of it. So it sounds like we still have some work to do with staff and getting the jab, as they say in Britain. So can we have the next slide, please? I just want to mention a couple of things. So this is kind of the steady as we go since the beginning of the new year. So there's an increase in well, the best vaccination is coming out of Israel, and some really good news actually. So the Israel Public Health is reporting that in terms of age 60 and older, that they're getting probably better than expected protectivity from the vaccine in the older adult population. They think they're actually going to exceed 95%, which is just spectacular. And they said that there's a few people that have gotten the infection after vaccination, but it's a very small percent. It's like 3%, 2%. So that's all within that 1 month window post vaccination. So it turns out that the vaccine takes, after the second dose, you require another 2 weeks before you start developing optimal immunity. And the other point is that there are reports of people getting COVID even after the first vaccine. So I actually have a colleague that developed COVID post-vaccination after the first dose. And the other point I want to make on this slide is that while the other countries like the United Arab Emirates have a very high vaccination rate, they wound up using the Chinese vaccine, which is only 50% effective. And that reminds me that it's a protein-based vaccine. It's very similar to the Johnson & Johnson vaccine. However, the Johnson & Johnson vaccine, which is a one-time dose, is 65% effective. So clearly the Israeli versus the United Emirates story show that the Pfizer Moderna vaccine is superior to the protein vaccines that are the more traditional kind of vaccines that we get when we get the influenza shot. Okay, next slide, please. And so this heat map shows that we've done a pretty good job in the area of getting as many vaccine doses out. So I think that 90% or better vaccination rate of our older adults in long-term care is a real thumbs up for all of us. So congratulations to all of our participants here for being part of that process. It's just really fascinating. I was talking to a close friend of mine from Michigan, who's like maybe 10 miles from the Pfizer factory, and he as a pharmacist was being asked to deliver and dispense vaccines in the area, and it turned out they didn't have enough vaccines. So here, and here he was right next to the factory. So it just goes to show you that the distribution still continues to be a problem. But nonetheless, we've done pretty good here in North and South Dakota and Minnesota. Next slide, please. I think really one of the important points is that this is the biggest vaccine campaign in the history of mankind. And like I say, we've had pretty good results here in North Dakota in particular. South Dakota is also good. So congratulations on getting those out. And we hope that persists with the general public, since we were focusing on long-term care facilities. I don't know quite honestly what's happening with the vaccine rollout in assisted living facilities, but I think they're in need as much as the nursing homes for expeditious delivery of the vaccines. Next slide, please. So for those that are trying to understand why we have somewhat of a low acceptance rate amongst nursing home staff, is somewhat explained by this curve, and I'll show you another one here shortly. But basically, you get about 15% on the left here, 15% of people that just ready to roll their sleeves up, and then you get another third of the population that you can see in the middle of the graph here, who are probably going to get it within a few weeks to a month. And then the remainder of the individuals are kind of wait and seers. They're thinking about it. They're prepared to get it, but they just haven't committed yet. So it's just a matter of timing, to get these folks on board, these what we call late majority adopters, and just trying to continually engage them in conversation so that when the vaccine is ready to go, that they're ready. And then 15%, you're just probably not going to convince these people. So they're considered the refuseniks or the laggards, and that's just part of the part and parcel with population dynamics and attitudes about accepting new things, in with the old or in with the new and out with the old kind of thing. Next slide, please. Yeah, so some of the tribulations and issues that come on is like, out of the blocks here for the sprinter, you want to be fast, but, when it comes to things like vaccinations, being first may not always be the most, first thing on anybody's mind. They want to kind of wait. There may be concerns about longer term side effects. I had a very funny comment from my spouse who said, yeah, well, when you get to our age, you don't worry about the long-term effects so much. You want to just kind of deal with the here and now. So those are my words of wisdom for my dear wife. And then, questions that come up about how long the protection will last. And I think, we have some ideas about that. We certainly know that the native infection, so if you get COVID, that you are protected for about 4 to 6 months, with the average being just right in between there, 5 months. But after that, you're susceptible to reinfection. And I think the real concern now is that being susceptible to the reinfection with these COVID 150 variants, and they're coming out of or have been identified out of South Africa and Brazil. So we need to kind of inform our staff that, even though you're getting vaccinated, that there may need to be boosters later, and we still need to be very mindful of our PPE and making sure that we don't acquire a second infection. So the issue that I also want to make is that if you do get a second infection after vaccination, 33% of those people will have symptoms, but the vast majority now, 2/3 of them, won't have symptoms. So again, when you're doing that symptom screening, there's people are going to slip through, and so we need to be mindful of that as we design our screening processes to identify these asymptomatic people. So quite honestly, the vaccines are going to create an even more stringent need for screening people. So that's why we're trying out the sniff test as an example to try to strengthen the screening process. Next slide, please. So this study out of University of Michigan reinforces what that graph was talking about. So you've got people like 66%, so 2/3 of the individuals that you can see here are likely to get the vaccine soon or within a reasonable amount of time. And then you have that 15% factor. Here it says 14% who just, come heck or high water, don't want to have anything to do with it. So again, the current research supports what we know about adopting new strategies, new ideas in a general population. Okay, next slide. Yeah, so I think part of it is just to amplify the message that we're first in line, as long-term care workers. And I think this is the first time in history that we've actually been first in line. We know that, as I've mentioned previously, that the long-term care industry in general is the most regulated. I think next to nuclear energy, is the most regulated industry and known to mankind. And it always seems like we're under the gun for, not doing this, not doing that. But here we are, first in line to get our sleeves rolled up, and boy, that's to me, it's a pretty good feeling that finally the federal government and others have figured out that of the importance of protecting our most vulnerable folks who are in long-term care. Next slide, please. So I liken this to the Queen. She's kind of an ambassador, and God bless her. She got vaccinated pretty early on, even though a lot of her the royals, the family had acquired COVID. We don't know her history, quite honestly, but She demonstrated her willingness to get the vaccine. And so I think it's part of that, being a good example, to be a good vaccine ambassador by listening to people who are disinclined or concerned about that. The other from leadership's point of view is try not to be judgmental, no finger pointing, say, well, everybody else did it, why aren't you? Um, and just to understand what their concerns are, and then to not necessarily counter the concerns, but just add information that might be helpful to them. So things like asking questions, having town hall meetings. Folks have been asking questions here with us about the vaccines, and we have a national clearinghouse that we resort to with all these different kinds of questions about what ifs and so forth that we can help provide information on. And that's our goal. So, you can use the ECHO COVID Action Network, this program, the ECHO CAN program, as an additional resource, as well as our expertise. If we can't answer a question, like this previous question I had with Dr. Carson from our who's the state consultant for vaccines, provided with what I call at the ready, at the moment feedback for a question that was asked by our coalition here. Next slide, please. So these are all the questions that come up, and we've mentioned a few of these about the length of its protectivity. So some of the answers are, well, it's hard to know because only time will tell as to when we start seeing the antibodies decline like they do in influenza. So when we get the influenza shot, the reason that we have to get them annually is because the vaccine efficacy starts to decline after 9 to 12 months. So we're only getting very temporary support for that. And then there is some carryover, so that you reduce the incidence of the disease or the side effects of the disease. And I think ultimately what we're trying to do is to prevent hospitalization with COVID. Because in some cases, you're not going to prevent the infection entirely. Certainly, we know in 5% of the population that the vaccine won't work. And then, other questions that need to be informative, like the last one there, can I get rid of the mask? And the answer is precisely what we talked about, which is no, you can't get rid of the mask because we're going to be with this for probably another couple of years and who knows how long. Not to be like I say, a naysayer. But with these variants coming up, it's likely that there's going to be breakthroughs with the vaccine, and we're going to need to have some boosters, just like we get boosters with influenza. So I think there is a parallel thought process about how we handle influenza and expect everybody to get influenza shots. I think the expectation for getting the COVID shots should be elevated to the same level. And I'm not quite sure why we're not there yet, but because of the newness, I think everybody's trying to treat this as kid gloves. But like I say, healthcare systems have a legal right to have everybody vaccinated for the recommended vaccines. And right now, the CDC has recommended all staff get the vaccine unless it's totally contraindicated due to allergies or some other doctor's orders. Okay, next slide, please. Just want to mention that they're incredibly, 20 million vaccines already, and there's like, less than 0.0000 something. How many decimals can you go for the 21 anaphylactic reactions that occurred? And most of these people had a known history of allergies, and a third of them had a strong reaction in the past. These are the people that carry EpiPens. And so there likely are individuals that have, like I say, a hyper immune system, and they get this, what's called a type 1 anaphylactic reaction. But again, they've demonstrated this for other allergies. These people tend to have multiple allergies. So if somebody says, oh, I'm allergic to cats or dogs, that probably is not multiple allergies. I mean, there would be something like, oh, I've got a seafood allergy, I've got, dander allergy, mites, and, you name it, the kitchen sink. And then finally, the AstraZeneca vaccine may have had some ill effects on really kind of end of life 75 and older individuals. And so now the AstraZeneca vaccine is being kind of curtailed for the terminally ill. And that gets back to our original question about what matters, in terms of vaccinations, that if somebody only has 6 months of remaining life expectancy, you can really raise the question about the usefulness of vaccinating those individuals who probably should be in hospice and palliative care. Okay, next slide, please. So just in terms of information about the vaccine, these fevers, aches, and GI upset are not anaphylactic reactions. Anaphylactic reactions, as we know, are difficulty breathing, tongue swelling, blotches all over the place. Just to share with you, my oldest daughter one time grabbed a batch of seafood gumbo that I made, and she had like red spots. She calls me up, and she says, "I've got all these red spots all over my face and chest." And I said, "Oh, you need to go to the emergency room." So, and ironically, she's tested negative now for shrimp allergies, which were in the gumbo. So God bless her, she got over her allergic reaction. But the other problems that people are having are mostly tiredness. And the other point that I was going to mention is that not only do these side effects indicate the vaccine is working, but they are more likely to occur, and I'll show you a slide on this. They're more likely to occur after the second dose, at least with the RNA vaccines, than they are with the first dose in terms of severe reactions such as GI upset. There are some controversies about whether you should use any type of pre-treatment, and so not recommended unless you're on a chronic aspirin regimen or Motrin, that you should not take these medications as a pre-treatment. Tylenol similarly has been implicated in reducing the immunization effect, and so certainly you can use Tylenol afterwards once you get these symptoms, but in terms of pre-treatment, it's indeterminate. All I can tell you is that if you have residents that are getting zoledronic acid, the pre-treatment with Tylenol really helps reduce those inflammatory responses to the zoledronic acid. So that's a good thing. Next slide, please. Yeah, so I just want to bring your attention to those orange bars there. So you can see those represent the severe reactions. Those are the really heavy fatigue, can't kind of get out of bed, extensive arthralgias, severe headaches. And you can see on the left-hand side there that these RNA vaccines, the first vaccine has no serious side effects, right? So then you look at the right column there, and just a small fraction of people pop up, in terms of their reactions. And so the biggest ones turn out to be fatigue is the most representative, and then fever is the next one. But after that, nobody really rated their, like the headaches being all that problematic, or myalgias, even nausea is really not in that mix. And so these are people who have not been exposed to COVID previously, got the vaccine. Now, it may be that the stories that we're hearing from, some of the nursing homes where they said their staff had a really strong reaction to the first vaccine is likely indicative that they had COVID and didn't know it, or they did have COVID and just got the vaccine a little too early. So that's our interpretation of what's going on there. Next slide, please. So I think really importantly to stress, and this may be a conversation point, is that COVID infection in 25% of individuals can cause long-term effects, such as chronic fatigue syndrome, and really odd chest pains, migratory pains. They also are finding that the autonomic nervous system goes dips and dives, and so there'll be spats of racing heart, like you'll get palpitations, sort of like an anxiety attack. And so I think, just understanding that there's a 1 out of 4 chance now that's coming out of England that somebody will have long-term effects from the COVID infection may provide some amplification or reinforcement for why you want to get the vaccine, which does not have any long-term effects that have been reported. Okay, next slide, please. So just to bring everybody up to date, that there continues to be research on these vaccines, and we might be able to see a vaccine pill, which might help deal with these variants. There's also vaccine patches. So this whole thing of getting intramuscular shots may go away here with the vaccines as they're being developed. Okay, do we have one more slide, I think, or not? Yeah, so the bottom line is the risks of COVID side effects, the infection itself, are much greater than the risks of vaccination. So however, we can do our best to be a vaccine ambassador armed with these facts, I think would really be beneficial. So with that, we're going to shift over to our quality improvement. So I want to hand this off. Are there any questions before we move on, though? So you can put those in the chat box if anybody has vaccine questions at this point. If you actually, why don't you, if you do have questions, put them in the chat box and we'll get to them towards the latter part of the session here. So why don't we just use this moment then, Kelly, to hand off to you with the quality improvement portion here.
Absolutely. Thanks, Dr. Durovich. And Greg, I wanted to see if you were on today. I know you said you were going to try to get on to discuss the
Yeah, I'm here.
Awesome. Guys, I want to introduce you to Greg Stomp. He has agreed to present a PIP that he had put together. And thank you, Greg, and I'm going to hand it over.
Okay, I guess to give the reason for the PIP in the first place was to give you a little history that we had gone quite a period of time in October with very few cases, just an occasional employee of COVID that we were dealing with. And then all of a sudden, about the 2nd or 3rd of November, within a matter of about 8 days, we had 1 positive, and then we tested again a couple days later as part of our outbreak testing. We had 14 more, and then we did rapid tests 2 days later, and we had 9 more, and then we did another PCR test and got 14 more. So within just a matter of 7 or 8 days, we ended up with 40 residents that were positive. And what one of the concerns is that we went from a 3 COVID wing, 3 room in our little COVID space that we had set aside to take care of our positives. We went from that to approximately half of the building, and we had to use the fire doors in the building hallways to try to separate and put plastic up and try to seal everything off. And we also then had a mix of negatives and positives next to each other and trying to get them all in safe spaces, and the rest of that was going on. So this was a very hectic period of time that we were dealing with. And while all that was going on, one of the things that we had done was we were using reusable gowns, and we had been taking them and putting them in plastic tubs and setting them outside the nurse's station or midway in a hallway, and so that the staff would be able to get those, because they were putting on a new gown every time they'd go into a different resident's room. And so it was available to them. When they got done, they put them in a like a large garbage can type thing for putting the dirty ones in, and then those were routinely emptied out and hauled back to laundry. We had because of the outbreak, we ended up getting a federal survey, and the surveyor that came in and went through and looked at everything, and I'm going to say fortunately for us, most of our outbreak was over. We were down to only 1 positive resident at that time. And so they were in our little COVID space that we had originally set up. And then in her observations, and when she went and looked around, she did find these tubs that were still on the outside the nurse's station and in the middle of the hallways. And she did notice that one of them had a gown that had a sleeve that was over the edge of the bucket, and it touched the ground. So she felt we did not cover the clean linens while they were in a in-use type of thing. We ran out of isolation carts and the rest of that where we normally store those outside of a room. And so we were just trying to get us all the product there and available for the staff. She also found in another location in our memory care area where the gowns were located was that none of the residents went in there and actually did anything with the gowns, but a resident that would be wandering in the hall could easily have gone in there and touched those gowns, and which would have contaminated them. So storing and transporting the linens and to maintain the cleanliness and keep them out of reach of the residents was basically the tag that we were cited. She said we did not have any issues with donning or doffing or hand washing or PPE use or any of the rest of that. It was just having these gowns out and not covered while they were out and available for use. So what we did was we then got a federal directed plan of correction, and that's the first time I've received one of those, where they told us specifically what our plan of correction had to say. And then one of the items that was part of that plan of correction was reach out to the QIO and have a meeting and go through this. And during that, we actually talked about putting this on as a PIP and making sure that we documented everything that we had done. And we did a root cause analysis and those kind of things, and did all of that as part of this. Now, there's some areas that we didn't go into great depth on that we maybe should have gone into more depth, but I think the big thing is we found that the root cause analysis and really forced us to look at what happens, especially in that kind of what I'm going to call a very chaotic situation that we were dealing with for that 7 to 12 days of new cases and moving people and the rest of that. And that really was what we needed to be able to do, was call a infection prevention timeout, where whatever we're doing, anybody can call the timeout, and then we would stop, review all the infection prevention measures that we're taking. Do we need to add anything? Do we need to change anything? And stop and fix it at that time. And then we can proceed back to doing what we're with the correct or with a better process than what we were doing. And I think that was it. We were trying to do so many things at once. We didn't really stop to think about our clean linens that were coming out of laundry, that they could barely keep those tubs full the way it was. And we had extra hours working in laundry, just washing the reusable gowns, that really never became something that we even really thought about much. So they did I just saw there was something popped up, said, did our facility audit laundry services for PPE? Yes. And actually the federal surveyor did too, and said they were doing all of that correct. And when they were taking the clean linens out and taking them, or taking dirty linens back in the laundry, everything was covered the way it was supposed to be. It was just the tubs that were in the hallways where we didn't put another cloth over those. So we did end up getting some other devices that we can keep everything covered now, and made sure we did that. So outside of that, that's kind of how we developed this and how we went through the root cause analysis. We then actually had our medical director review it and kind of sign off on it also, to see if there was anything that he could think of. And we then proceeded. And since then, we have now been put back in compliance for this particular deficiency. But we've had about 5 or 6 other infection prevention surveys prior to this, because of the occasional cases that we would get. And we didn't get tagged on any of those, but this one we did. And I think that's all I really have on this.
Great, thanks, Greg. And I'll say, I know I mentioned it last time you spoke, but I really love the fact that you implemented an infection prevention timeout it's a great opportunity to look at your system as a whole. Timeouts are pretty typical in like surgical settings, but I like how you have rolled it into your facility to catch things, to be proactive. So kudos to you and your team. Dr. Jarovich, Michelle, do you have anything to add before we go into the QI stuff?
Yeah, I do. Thanks, Greg. Wonderful presentation. And this is exactly what we're hoping to accomplish, where each of the facilities, facility of the day, we'll send you a box of candy. I think, Greg, I don't know if you got your box of candy yet, but thank you so much for doing this. And by the way, the boxes are for the staff, so we're trying to distribute those Ferraro candies or whatever. To reward the staff for their participation in this program. But, as you look at this PIP that you conducted, it just, you start dissecting it. That's why I asked about the laundry question. So then it gets down maybe even a little bit more granular. Was there a review, for example, on the dwell time for disinfecting the carts or the, tubs? So those are kinds of things that I would imagine would be all part of the quality improvement process. To assure things like I say, just giving permission, if you will, or direction to the laundry staff to do some self audits. Like are you using the appropriate dwell time for disinfection using the particular agent that you're using, whether it's a 5-minute or a 10-minute dwell time, depending upon the agent. So
Yeah,
I don't know if you have any thoughts.
Yeah, that was a really good point there. And our policies themselves, all the way up to this, had been our one product that we had a 10-minute dwell time, and they were laundry was very familiar with it. And when questioned by the surveyors and the rest of that, they were able to answer appropriately and show them how they did wipe everything down and clean things and the rest of that. So that was part of our policy. We did discuss that a little bit in the root cause analysis. I don't think you have a copy of the whole root cause analysis that we did, but we did address some of those things in that. And then, and the staff was very good about it and was able to respond to all of that. The only thing I asked them was, as I said, if you knew these things were supposed to be covered out here, why didn't you cover them?
Yeah.
That was the only thing I had, but it was an expensive lesson to learn on this, but I'm glad we did it, and I'm glad we went through the process.
Yeah, no, it sounds like a invigorating process there. You're better for it, but yeah, it's one of those movies, where they have the ninjas have to go through all this holy heck, to get stronger. So the other question I have, were there any surprises during this process for you in terms of staff either stepping up or, like you say, kind of, not stepping up? Were there any things that you identified in terms of staff engagement?
I think the only thing is that where staff maybe felt that they couldn't stop us. So that's why we really wanted to introduce that timeout, that anybody can call a timeout. We did tried to have, we had a CNA and the housekeeping supervisor and our IDT team and whatever as part of that root cause analysis. And I think that our IDT team was very comfortable with, saying something if they saw something.
Yeah.
But we wanted the CNAs and the others to feel that they had that ownership also.
Yeah, boy, that's so important. And I don't know if you want to call it empowerment, but I think part of the hassle of this is that if somebody speaks up and they identify a comrade in arms, they go like, "Oh, you snitched on me." That's where it really gets to be a problem that people are reluctant to mention something because they think somebody's being singled out. And again, it's just trying to what I want to say. Disarm people, dissuade them, just not to worry about that, and that everybody accepts self-criticism. I think is part of the culture and change. That here we are a team, and I mean I even look at my own clinical practice. At moments that I forget to do something, I look back and I do chart review, and I said, oh gosh, I forgot to do this cognitive testing on a 90-year-old patient, what was up with that? So then you can do better next time. So there's both that sort of self-reporting of missteps as well as observing others. And I don't know, we've floated the idea of a buddy system, to further accentuate that, the CNAs have buddies that they can support each other. I don't know if you saw in the TV news last night, but there was a wonderful story about a young man from New Hampshire who became he was a 10-year-old junior governor or kid governor elect. And he devoted himself to his platform to creating childhood buddies to help deal with depression during the pandemic. And it was just very, very touching to see, have that concept of a buddy system where we support each other. So I think, incorporating that in identifying a buddy system within the facilities is good, both in terms of, quality improvement, but also, as we'll see later, about, mental health improvement. So that's kind of my the soapbox for today. Do we want to do the video here then, Megan or Kelly?
Yes, we can do this video, and I'll continue on the QI bit when if we have a few minutes left after this after this video. But I also just wanted to add on Greg's PIP. I really like the idea of you including all the staff, and Michelle had posted that on the chat as well, to allow all staff to do it. It really just builds that culture. And as Dr. Jarovich mentioned in his clinic, where he's able to say, hey, I missed this. It's really about the leadership leading by example on how to respond if you are called on a timeout. So once again, I think that's a great idea, and it definitely can build your staff culture.
Today, we're going to talk about promoting safe care transitions for admissions, discharges, and transfers in and out of the nursing homes during COVID-19. I'm Ellen Flaherty. I direct the Dartmouth Centers for Health and Aging. And today's objectives focus on three things. Focuses on safe admission process, a safe discharge process, and to talk about evidence-based models that support reducing avoidable facility transfers. So when we start to think about admissions to the nursing home during COVID-19, one of the first things we think about is, how are we screening people? The purpose of screening is to identify the most appropriate cohorting for that patient. And we screen based on clinical indicators and symptoms that you all know: fever, runny nose, sore throat, shortness of breath, and also the potential history of exposure for the resident. Has the resident come in contact with someone who's been confirmed COVID-19 for the past 14 days? The purposes of that, as I said, is to cohort that new resident. Cohorting, as you know, is an important part of admitting and readmitting to really minimize risk and exposure and the spread of the infection in the facility. There have been other sessions on this, and you all are, I'm sure, experts in this at this point. And here are some guidelines and updates for further information around cohorting. So when we think about cohorting, we think about three distinct types of units that we establish in the nursing home: a COVID positive unit, an admission observation unit, and then a general standard COVID-free unit. And based on the screening that we did initially, we have three categories of residents. We have residents who are positive, who will go to the COVID unit. We have residents who have screened positive, although may not have a positive test. Those residents should be tested and admitted to an admission observation unit. And then we have the third category of resident that has no COVID indicators and no negative test for less than 72 hours. And those residents are also placed in the admission observation unit. So the admission observation unit potentially should have private rooms if they're available. And if not, we cohort based on exposure and risk. So when was that individual exposed? What is their risk? And trying to determine how best to partner them with somebody who has similar exposure or risk. We should have dedicated staff, and those staff will be wearing full COVID PPE, as we say. Residents will stay on this unit for 10 to 14 days. Again, a lot of the local regulations will come into play here by state. Some facilities will test people before they leave the admission observation unit, and others will not, and they will just, after 14 days, go into general care. COVID unit, private rooms if available, and again, cohort based on exposure and risk. When was the patient diagnosed? When was the first symptom? And trying to room people, if private room is not available, with somebody with similar exposure and risk. Dedicated staff, and these residents can move to the general unit 7 days after their first symptoms or a positive test. When we think about discharges for residents, and very often when we think about discharges, they're going home. So we want to make sure that we obviously do our usual discharge instructions with some explicit information about whether or not they had COVID infection, when they were diagnosed, when was their test done, how far past their testing and or symptoms is it, and certainly their immunization status. It's important to communicate with families who may want to take a resident home, that any readmission would require the 14-day admission observation unit stay, regardless of the length of time since discharge. So some families who wanted to take individuals home for a holiday needed to understand that upon return, that individual would have to go back to or likely go to the admission observation unit. Key elements of safe transfers. We all know the challenges of complications and adverse events during transfers. So we think about one of the most important things is certainly having a good understanding of what somebody's goals of care are before they're transferred. And if that transfer is consistent with their goals of care, making sure that that is clearly communicated and documented on the transfer papers. During the event, an acute event that is prompting this transfer, communication between nursing, medicine, the patient and the family and or the surrogate is extremely important to discuss the potential transfer. And certainly a warm handoff to the receiving institution is critical. Typical transfer documentation, of course, and to be sure that that standard documentation also includes elements around COVID, their COVID history, and certainly their vaccination status. I want to talk for a few minutes about some of the models that exist to reduce nursing home transfers. Several of these models, Boost and Project Red, are hospital-based models focusing on reducing readmissions when somebody is discharged from the acute setting. Three of these models, however, are focused in the nursing home: Interact, Optimistic, and Raft. Interact, which is a very well-known model, is an intervention to reduce acute care transfers. It is a quality improvement model that focuses on managing acute change of resident condition and uses clinical and educational tools and strategies to not only communicate between disciplines from the nurses to the providers, but processes in place to identify any early changes in the hopes of identifying anything early to prevent a transfer or admission to the hospital. Many of the Interact tools are available free of charge, and this is the website to access that. Optimistic is another nursing home-based model, optimizing patient transfers, impacting medical quality, and improving systems, transforming institutional care. This is an ongoing CMS project led by Dr. Kathy Unroe that you've heard from before, and it's focused on avoiding unnecessary hospitalizations. This model focuses on adding staff, embedding them into each facility to extend clinical resources by mentoring nursing staff, implementing evidence-based tools to improve care and communication, and leading efforts in advanced care planning, again, that you heard from Dr. Unroe about. And here is the website for additional information. Raft is a model that was actually developed at my institution, Dartmouth, reducing avoidable facility transfers. And this is a quality improvement model that focuses on three main things: eliciting goals of care before an event, what we call what matters most; acute event management by trained on-call clinicians; and then post-transfer debrief that provides an opportunity to educate providers around how to reduce these transfers. This link is for a paper that was written, and that was written in AMDA, and you can access that full text. So in summary, when we think of safe transmissions, we think about focusing on pre-admission screening, cohorting, and in general, just avoiding transfers. That happens often through goals of care conversations, pulse, MOLS, COLS, prior to an event. Communication is essential to have safe admissions, safe discharges, and safe transfers. Communication with a warm handoff is key for all of these. Thank you.
Great. So just a reflection, and were we going to go to a case study now?
Dr. Jervich, I'd sent you a message over. I'm not sure we'll have time to go through it completely.
Yeah.
But I just didn't want to miss the ending session call, and I'm happy to stay on after the 1 o'clock hour and still go through that section if anybody wants to stay on.
Yeah. So we've kind of gotten to the hour here. Yeah, so I was just going to mention one of the take-home messages from Professor Flaherty, who's a colleague friend out of Dartmouth, that she has this RAF program that was integrated with geriatrics expertise. So to a certain extent, we have our geriatricians integrated into this EchoCan program, but our vision is to really bring that geriatric expertise to the facilities through this coalition. So as we're looking down the road here in 2021, that we want to maintain that relationship so that we can bring our geriatric expertise for different things like, good transfers of care. And I can just share with you that when you implement geriatric principles of care, in the context of quality improvement, you can have some really wonderful outcomes, such as reduction in hospitalization rates, for the patients that residents that end up in the hospital, they have shorter lengths of stay, fewer bounce backs. And all these things are a good thing in terms of what the hospital and long-term care facility relationship might look like. And by enhancing your programs with the geriatric expertise, I mean, not that I want to do any self-promotion here, but the idea is that the geriatric principles of care, when applied through quality improvement, can really make a big difference.